Cutaneous senses will be the first section about pain. As I said, there were a couple of really short concepts that I'm going to finish up with about touch. So, and since we didn't get to talk about visual attention, I really wanted to go ahead and share this figure, that it's really important what we are paying attention to. If we're not paying attention to something, we can see their stimulation on the sensory receptors, but that cortical, so our cortex, is not responding in the same way. And that's what this is showing. So this is showing a study where they were rubbing across a monkey's paw. And in one condition, the monkey had a different, so a visual attention task. And in that visual attention condition, you can see that then there is very little neural firing. In another condition, they were supposed to pay attention to that touch, and if it was a certain kind of touch or moving in a certain direction, they responded. In the tactile attention condition, this is where we see the neurons are firing, right? Because consciousness is happening in the cortex for humans, and we need to pay attention to something to be consciously aware of it. Pain, the kind of pain we will talk about is nociceptive pain, so where we have any extreme heat or cold, severe pressure, sharpness, chemical pain. All of this is caused by activation of nociceptors, as they are called. They are bare nerve endings, similar to what we saw in the Pacinian corpuscles, but without the corpuscle kind of protecting them around that. There are other kinds of pain. Inflammatory pain, when we have some kind of damage to tissue, or we have inflammation of joints, or tumor cells are causing damage, that kind of inflammatory pain. We also do have or can have neuropathic pain, so lesions within the nervous system, other damage within the nervous system. The most common neuropathic pain that gets talked about is carpal tunnel syndrome, that's in the nervous system. He actually talks a little bit about phantom limb pain, which would be a neuropathic pain. They used to think of it as something that was coming from the body or the nociceptors, those sensory neurons, but it turns out that that is something that is happening in the brain. The way they talked about nociceptive pain is basically we have this stimulation of the nociceptors, these fibers that are going to tell us that we are in pain, and then we feel pain. But we all know that it's more complicated than that. I have various examples here of how other aspects of our attention and sort of what's going on with us can influence our experience of pain. So this first example, which was the example that really kind of set Melzack and Wall to say we need a better model of pain, and set them to creating or coming up with this gate control model of pain. You can see at the bottom there, this was in 1965. We still talk about the gate control model as our model of pain, even though we are seeing certain complications and some things they'll have, they'll be able to get more specific information about or come up with a formula, a mathematical formula, but pain is very complicated. And so to some extent, to really try to explain various aspects of pain, they stick with this gate control model, even though it is quite old and it probably needs to be updated in many ways. But one of the things that caused them to create the gate control model or propose the gate control model was this study by Beecher in 1959. So Dr. Beecher was working with patients at Anzio Beachhead, and he found that these soldiers who had some pretty severe wounds, so I ended up looking up this study because various reasons. So pretty severe wounds, like a broken leg, or I think they needed to have more than one limb being not able to be used, open stomach wounds. He did not examine anybody with any head wounds because he wanted to not have any brain I'm just doing this terribly. Blah. The gait control model in a nutshell, pain signals enter the spinal cord from the body and are transmitted to the brain, but we also have these additional pathways that can influence that signal, either as they call it, opening the gates of pain or closing the gates of pain, and that where those gates, or what we're going to call a gate, is located in the spinal cord. And I do this a little bit better, I feel like, with my picture, so I'm going to move on to my picture of the gate control model. And I do have these extra pictures on the right from Laura Freeberg's, I think it's called Biological Psychology textbook, not to add more structures and things, but just because things are really clearly labeled, and for me, I find it helpful, and I feel like students do, but then sometimes people laugh at me for saying, hey, I'm just trying to help you. I'm not trying to give you more to memorize. But so if we're looking in the spinal cord, so we have the dorsal root ganglia, we have those neurons just outside of the spinal cord, and they're going to synapse in the spinal cord. They're going to come in to the spinal cord, and they can communicate directly. So those nociceptors, because we're going to talk about pain, those nociceptors can communicate excitatorily and directly to the transmission cell, where that T cell, the transmission cell, that's going to communicate to the brain. Or they can communicate through these excitatory substantia gelatinosa neurons, or SG neurons. You don't need to know that, but that's another area that they can synapse. It's then going to have an excitatory communication with the transmission cell. But we also have, so those L fibers are referring to large fibers. If you think about what happens when you fall off your bike and your mom rubs up and down on your arm, well, there are these large fibers as well that are going to communicate up the medial lemniscal pathway, right, and communicate more quickly, and they can be sending inhibitory information. They can be sending excitatory information to the transmission cell, as this figure shows, but they can be sending excitatory information to neurons that are then going to communicate inhibitorily to the transmission cell. So basically closing the gates to pain. And so when our mom is rubbing up and down our arms, she doesn't really know probably the neural mechanisms behind that, but there is this inhibition in the system from those large fibers. The other bubble that's up there is, I think they call it central control. I often call it cognitive control, even though central control is a much better term. So the information coming down from the brain can communicate excitatorily, and in the gate control model, it really is communicating to inhibitory substantia gelatinosa, so it's helping to close the gates of pain. And we can think of this as things like endorphins, adrenaline, distraction, and that's how usually that central control is communicated about, or how they talk about it. Some additional studies looking at how, again, this appears not to be a direct pathway model wouldn't be explanatory for a lot of this. One is hospital study where they basically told patients what to expect and to relax, and those patients were sent home 2.7 days earlier and requested fewer painkillers than the patients who had care as usual or standard care, where this information wasn't provided. So I've been in the hospital a few times recently with my mother and with my brother, and they are often really quite uninformative. You really have to chase someone down to try and figure out what's going on, and a lot of times both the tech care and the nurses don't really know or aren't supposed to tell you certain things. I don't know. It's very confusing, and it's actually kind of difficult to find out what to expect. And just being told what to expect and to relax is really helpful. But it does show the effect of expectation on our experience of pain. In a great study that I used when I first started talking about why study, like how can we help humans with this, is this hospital study that started with, I think his name is Andrew Portnoy. He was working on a gas tank that exploded and had third-degree burns over something like 42% of his body. And if you've seen someone be debrided where they're basically pulling off the bandages and putting on new bandages, those bandages that they're pulling off, because of the burn, there's no real skin there, so they're stuck to like blood vessels, and it's very painful. Being debrided or having those bandages taken off is very painful. And so they asked him to rate his pain when they did this standard care as usual. It's often how they refer to it as CAU or SAU, standard as usual, or care as usual. And it was on a scale of 0 to 10. He rated it up at something like a 6, which seems low to me, but he said, I think it was around a 6. And then they gave him this virtual world the next time. So they debrided him. They put him in a virtual reality machine, or they put that machine around his head, and he had what I consider to be a relatively boring task of, there's a spider that comes in the kitchen, and he chases the spider and puts it in, gets it to the disposal and grinds it down the disposal. And then another spider. So I'm just being distracted, and he rated his pain as down at something around a 3 or a 4. So quite a bit of lowering on that pain scale. And they have now done quite a few studies looking at virtual reality, and it does appear that for a lot of things, that is a better distraction. It helps people more with their pain than positive pictures, watching a video, listening to pleasant music. That it is kind of the winner. If I can move around and do something, the thing is that you're truly are completely in that game, and you actually cannot look at, right, your arm or whatever they're doing to you. So you have that really powerful distraction. Studies now have looked at the content of that distraction, or really the emotionality of that distraction. Is am I causing a more positive emotion or a more negative emotion? In this study by DeWeed and Verbaeten, they had participants look at either positive pictures, neutral pictures, or negative pictures that were rated by these were college males, and they were rated by another set of college males as either positive, negative, or neutral. And then they had them have their hands immersed in very cold water. They were told to keep their hand immersed there for as long as possible and withdraw it when it began to hurt. And so there's no differences in the rating of pain here, but if you see the amount of time they were able to tolerate the cold water, it was longer at about 100 milliseconds, 120 milliseconds for people who were looking at positive pictures than so significantly longer for positive pictures than for neutral or negative pictures, which were right around 80 and 70 milliseconds respectively, and those were not significantly different from each other. We see a similar kind of thing, except here it is the intensity ratings, and its intensity of pain, but also the unpleasantness of pain. So they're rating both of these on a 0 to 100 scale, and they compared people who sat in silence, people who listened to unpleasant music, which they have as a Sonic Youth song that I didn't know, but I listened to. I actually like Sonic Youth, but it is a relatively unpleasant song, gotta say. And then a pleasant song, which was Rossini's William Tell Overture, which is actually very pleasant and calming. Anyway, if you notice that when their intensity ratings and their unpleasantness, their ratings for unpleasantness were very similar for silence versus that unpleasant music. So the unpleasant music didn't seem to make it worse or better. But the pleasant music, you can see that they're significantly lower in their ratings of the intensity of the pain, and they are significantly lower in their ratings of the unpleasantness of the pain. In this hypnosis study, Derbyshire et al. Had people rate their experience of pain from 0, meaning no pain, to 10, being extreme pain, in 3 conditions where they either physically induced pain, so they had these stimulators that created heat, and they were physically inducing heat impulses enough to cause pain, where you can see the pain rating is at about 5.7. Hypnosis-induced pain, where so there is no heat, it's not turned on, but the experimenter suggests that painful heat is presented, and people are rating their pain up at 2.8, which isn't very high, but they did this in comparison to this control condition, where under hypnosis, the experimenter told the participant that the stimulator was turned off, but they also told them that they should imagine that they were experiencing a painful heat. Where now some people are reporting feeling heat. Like I can imagine that, and it's causing me to feel that heat, but none reported feeling any pain. So really down there close to zero, right? Zero pain. So to me, this suggests that that central control, even if we think, oh, okay, phantom limb pain is some special situation where maybe we didn't really understand it very much, or that it was coming from the brain, but this suggests to me that that central control can have an excitatory influence on the transmission cell. And if you think about things like specifically paying attention to the pain, or having some acute stress where you start to notice pain more, it does seem like that central control should be allowed to have this excitatory kind of influence on the transmission cell, but from the model, it really goes through inhibitory substantia gelatinosa, so the model is only allowing for inhibition, which doesn't appear to be true to me. Okay, if we get to the brain and pain, he has a new picture for this, but I like this because things are a little bit more clearly labeled, although you can see from my additions there were things missing as well. So when we are feeling pain and we have this pain matrix, some of the regions that we see involved in pain, it's going to go through the thalamus. So the various thalamic nuclei are going to be involved. We're going to feel that pain on some area of our limbs or body, right, wherever that pain is actually coming from. The somatosensory cortex is going to tell me about that, and potentially some of the posterior insula. So you see I have insula off to the side there as well. It's not pointed out, but he is going to talk about the insula, and so I am too. And the insula is a huge structure. If you look at the where he's pointing to the anterior cingulate cortex, so now we're looking at more of the affective or emotional component of pain. We just talked a little bit, very briefly, about pleasantness versus unpleasantness, that this is unpleasant, right? That typically when we're talking about our pain, we can have a very physical way of talking about it. It's sharp, it's biting, it's hot, it's throbbing, it's dull. These words that are clearly physical, talking about that intensity and the physicality of it, where we're probably going to be feeling that in the somatosensory cortex and the posterior insula. But we also have words like, right, it's frustrating, it's debilitating, it's awful, all of those emotion words. And when we're thinking through that aspect of pain, most likely the regions that are activated, that are kind of adding into that, are the anterior cingulate cortex and the anterior insula. So S1, ACC, those are the ones he really talks about. We will see one study also talking about the insula. But other regions are also involved, so the amygdala telling me this is unpleasant, and potentially communicating to the autonomic nervous system, communicating through the hypothalamus to the adrenal glands as well, so the hypothalamus being involved, the hippocampus, me recognizing certain contexts maybe where I feel more pain, laying down those explicit memories about this pain, so I can learn potentially from this situation, which the amygdala is more conditioning and unconscious learning. And then the prefrontal cortex, which they typically talk about the prefrontal cortex as being I can distract myself from pain, right? That I can purposefully go pay attention to something else. I'm oversimplifying. These are lots of brain regions. And I usually do this thing on my exam saying, you can either explain or describe 2 of those, or you can really learn the pain matrix and just be able to list off structures. That's usually the way I ask a short answer question, if that's what I end up doing. And so the 2 that I assume people are going to explain and describe, doesn't always work out this way, are the somatosensory cortex and the anterior cingulate cortex, because we're going to talk about both of those quite a bit with various studies. And this is a good place to end the pain part 1 lecture, so I'll just do this kind of bridge for our final lecture for today.